Hey everyone, and welcome to sqadia.com. Today the topic that we'll be talking about is effects of radiotherapy on the oral mucosa and how we're going to manage it. So, radiotherapy is the most common treatment option which is used for head and neck malignancies. The purpose of this radiation is to basically destroy the neoplastic cells and spare the normal ones. Radiation usually interferes with the nuclear material. Now, those cells which have a higher reproductive rate, like the hematopoietic cells, epithelial cells, endothelial cells, and as well as the malignant cells, like we know, these have a high turnover rate. So, the radiotherapy targets them. Hematopoietic cells and the epithelial cell, they have the highest. And because of this, the radiation targets them and eventually it results in undesired effects. Now, first of all, we're going to be talking about the effects the radiation has on the oral mucosa. So let's start with the short-term effects. When the radiotherapy starts, after that, for 1 to 2 weeks, there is going to be redness or erythema of the oral mucosa, which eventually leads to mucositis. So in the 3rd week of the radiation, the patient is going to be experiencing mucositis, which is basically due to the decreased cell renewal of the epithelium. The mucosa becomes atrophic and it becomes ulcerated. Now, the patient may also experience pain, dysphagia, and a loss of taste. The treatment is basically palliative. We can only help to relieve the symptoms of the patient. So we can ask the patient to carry out good oral hygiene, use viscous lidocaine. Now, the viscous lidocaine is going to help the patient and is going to give a soothing effect to the patient. And antibiotic lozenges and antifungals can also be prescribed. These are going to prevent any superimposed infection that may occur on an already damaged oral mucosa. So, in the long-term effects, there's going to be delayed healing. Even after a very small injury, there's going to be delayed healing. And if an ulceration may form, it's going to take months to heal. The mucosa may appear pale. This is because there is decreased vascularity in that area because the radiation is targeting it and damaging the blood vessels as well. Just like we discussed, the endothelial cells are getting targeted as well. There is also going to be radiation-induced submucosal fibrosis, meaning fibrosis in the submucosa. Now, this occurs basically because the fibroblasts are going to get differentiated, which is going to result in fibrosis. Interleukin-2 is secreted as well as intercellular adhesion molecules, ICAM1 and CD44. What these do, they create linkage and a bondage between the fibroblasts, so an increased level of fibrosis occurs. Now let's look at the effects this has on the mandibular mobility or the jaw opening. Now, if the radiation is directed towards the TMJ and the muscles of mastication, this is eventually going to lead to degeneration of the articular surfaces and the fibrosis of the muscle. So basically in this picture, we can see the articular surfaces. We can see that there's the condylar head and there is the glenoid fossa in which the condylar head is resting. So these articular surfaces are going to degenerate. Trismus is the result of the radiation and it occurs in the first year when the patient starts radiotherapy. The interincisal distance may be reduced to less than 20 mm. This causes an eating difficulty, speech difficulty, and of course there's going to be difficulty on the dental chair as well because the patient is not going to be able to open their mouth to carry out any dental treatment. Now, how are we going to manage trismus? First of all, when the patient starts radiotherapy, it is important that we advise the patient to start physiotherapy. The patient needs to do jaw exercises daily. These jaw exercises are going to help the patient open their mouth to a maximum limit and give the jaw good mobility. Some of these exercises include repetitive mouth opening and closing. So the jaw goes up and down, protraction and retraction, and as well as lateral jaw movement. Next, we're going to prescribe the patient anti-inflammatory medication, and we're going to give him medication to manage the pain. NSAIDs like naproxen sodium and muscle relaxants like baclofen may be advised. Now, if the pharmacological intervention fails, then we move on to surgery. Coronoidectomy is a procedure in which the coronoid of the mandible is to be removed. This helps to increase the interincisal distance post-operatively. So, as we can see in this picture, this arrow is showing where the temporalis muscle attaches, usually on the coronoid. But when the coronoid is removed, the arrow now shows where the temporalis muscle is going to be now attached. Now, as we can see that the temporalis muscle has freed the mandible, and now the mandible is going to be able to carry out free movements. So this immediately increases the interincisal distance post-operatively and helps the patient to open their mouth a little more. Another option is forced mouth opening. This is done under general anesthesia, but just as the procedure sounds, forced mouth opening, it has some adverse effects. It is usually short-lived because the muscles are going to get fibrotic again and then pull up the jaw back into its original position. And this is a less controlled procedure. We can't really control how much the jaw can be opened. And there is always the risk that the alveolus may fracture. It may also cause soft tissue rupture. Now, if the radiation is directed towards the salivary glands, usually the salivary gland epithelium has a very slow turnover. This means it's going to be less damaged by radiation. But that said, there is going to be obstruction of the blood supply. And this will cause the gland this will lead to the gland becoming atrophic, fibrotic, and there's also going to be degeneration of the gland. So all of this is going to result in xerostomia, meaning dry mouth. So when there is not enough saliva production, there is going to be a lot of problems like difficulty in chewing, there's going to be loss of taste, there's going to be halitosis, bad breath, and there's also going to be burning sensation and even cracked lips. The oral mucosa is going to be more vulnerable to fungal infection and even bacterial sialadenitis. As we know that the saliva production has reduced, there is a chance that there may be a blockage, a stone formation occurring in the salivary gland duct. So that is going to block the ductal epithelium. There is also going to be an inability for the patient to wear the dental prosthesis. Now, why does that happen? Now, that happens because the saliva provides adequate medium for suction. So, if there is less saliva, the dental prosthesis is not going to be able to sit on the oral mucosa as well as it would usually be. And there's also a chance of rampant caries. Now, let's move on to the treatment options for xerostomia. The patient is advised to sip water throughout the day to help with the dry mouth. We can also use salivary stimulants like pilocarpine, 5 mg of pilocarpine 4 times a day. The patient will also be prescribed mouth rinses with 0.12 chlorhexidine. This is an antibacterial which is good for plaque control as well. Topical fluoride application to avoid any caries, and the patient is also advised to avoid sugar intake, coffee, and alcohol. Sometimes sugar-free gums also help with the stimulation of the saliva. Now, let's see how pilocarpine works. Now, pilocarpine is basically a cholinergic parasympathomimetic agent. This acts at the muscarinic acetylcholine receptors. It increases the secretions from all the exocrine glands. So, that pilocarpine is going to have some adverse effects. These are going to be like sweating, nausea, diarrhea, and chills, flushing, rhinitis, dizziness, headache, asthenia, urinary frequency, vasodilation, and bradycardia. Now let's look at the effect radiotherapy has on the bone. Osteoradionecrosis. This is the necrosis of the bone which occurs due to the radiation. It is an inflammatory condition which results due to the ionizing radiation. There is irreversible damage to the osteocytes and the microvascular system. Injury occurs to the bone remodeling system. Over here, I've attached a picture. This shows us some of the cells of the bone. The osteocyte, which is the bone maintaining cell, osteoblasts, which form the bone matrix, osteogenic cells, these are the stem cells, and the osteoclasts, which resorb the bone. So the balance between the osteoclasts and the osteoblasts is destroyed. That basically consists of the remodeling system. So this remodeling system does not occur, and the sharp areas on the alveolar ridge will not smoothen themselves. There is also decrease of the microvasculature of the bone. The tissue becomes hypovascular, and that eventually leads to the necrosis of the bone. The mandible is usually affected. Now, why does this happen? This occurs because the mandible is much denser. The bone of the mandible is much more denser as compared to the maxilla, and also because it has a single artery which supplies all of the lower teeth. Some of the clinical features include pain, orofacial fistulas, exposed necrotic bone, and pathological fractures or suppuration. Now, what are orofacial fistulas? These are basically a pathological communication between the cutaneous surface of the face and the oral cavity. So the oral cavity is basically communicating with the outside. Now let's look at the management. If there are any pre-existing periodontal conditions, that it is most likely that it is going to worsen and cause caries and continued periodontitis. So all the teeth which have a poor prognosis need to be extracted before radiotherapy. A full workup is done by the dentist and the teeth are evaluated. There needs to be sufficient healing time interval between the radiotherapy and the removal of the teeth. It is suggested that almost 3 weeks should be given to the patient after the removal of the teeth. Oral hygiene measures and instructions are given to the patient, so the patient can maintain the oral hygiene. Osteoradionecrosis also results in small lesions of the bone. For that, the patient is advised to carry out daily saline irrigations at least 10 times a day. 0.12% of chlorhexidine mouthwash, which acts as an antibacterial agent to prevent any superimposed infection, and we may also give the patient antibiotic coverage, which include penicillin and metronidazole for anaerobic coverage. Now, if the osteoradionecrosis worsens, then we can also carry out some surgical techniques like sequestrectomy. In this, the sequestrum, the necrotic bone, is removed surgically. There is also an option to surgically resect the necrotic bone. And we can also use hyperbaric oxygen therapy. In this, pure oxygen in an air pressure which is 1.5 to 3 times than average is used to give oxygen. This eventually improves the symptoms of the patient. Now, some of the other most common effects that we usually hear from a patient undergoing radiation therapy is basically a candidal infection or bacterial infection. The oral mucosa, like we discussed before, is erythemetic, meaning it is more prone to catching any bacterial or fungal infection. Candida albicans usually thrives well in the patients who are undergoing radiation therapy. So for this, topical antifungals like nystatin and oral rinses, which consist of 0.1% chlorhexidine, are advised. So now guys, let's summarize everything that we've studied. First of all, we need to evaluate the patient who needs to undergo radiotherapy, and we're going to evaluate all the teeth using x-rays and clinical examination and remove any teeth which have poor prognosis. Then we need to prepare the mouth so that no surgical procedure is needed after the radiation. Fluoride application, mouthwash, saline rinses, and the patient needs to maintain good oral hygiene. So guys, this was everything. I hope you learned.